Evening, all. Good afternoon, good morning. And we all know that there are candidates who have joined from different parts of the world. So, welcome, friends, to our discussion on the EDIC Part 2 preparatory course. With me, I miss Dr. Sananta, who is my course code director, who is on vacation, so he is unable to join. And also, my course faculties, Dr. Manjunath and Dr. Jitendra, very young, dynamic intensivist who have taken the time out, and also they would be helping you in this journey to success. So, as usual, we all know you all are brilliant. We are all in the same phase of our life, but it's okay that we are trying to at least guide you. We are not trying to teach you also in the path to success for the EDIC Part 2. So myself, Dr. Tapas Kumar Sahu, just little bit brief introduction. I don't want to share my CV, but yes, we are trying to build up a proper curriculum for our competitive critical care exams. And believe me, the response was something we never thought about. Last 2.5 years back, when we thought about starting one academy to help the candidates in their critical care exam preparation, so we were not very sure that how it would be appreciated or the response would be taken, but definitely the response. Dr. Manjunath is with us and Dr. Ditendra. We all have gone through the last 1.5 years or 2 years. So definitely the candidates, the trainees are getting benefited, and we are really thankful to all of you for your kind support. Now, I am not going to the problems that we face in our critical care exam preparation, but yes, there are certain things that has happened in last maybe 10 to 15 years of time that critical care medicine as a super specialty is getting more and more recognized all over the world. And the different exams that we try to click for our affiliation as well as our the credentials, those need focus, strategy, and practice. And believe me, European Diploma of Intensive Care Examination is one of that, and it is more comprehensive nowadays. And definitely, those exams need more proper planning to appear as well as pass. So it is not a cake work that you will be only registering and just wait for the exam date and you appear and you will be like just clicking. No, it is not there. Maybe before 5 years, 7 years, 10 years, I would not say at that time it was easier, but yes, at that time it was on site, but now it is online. So that makes it more difficult, I would say. You may be knowing lot of things, but that hardly 1 minute like of your CBS question, you may not comprehend properly or put it on the table for the examiner to know that you are okay, you are knowing the things in the proper way as a normal attending in the ICU should do. So, for that reason, definitely the preparation needs to be guided, and definitely we need to start it early for the success. So why we thought about this type of academic venture last 2.5 years back, and the European Diploma of Intensive Care exam was the first exam preparatory course that we have started with, because we felt that during our preparation, our training period, maybe 10 years back, there was no structured course format, and we all had to go through very heterogeneous and unplanned academics. And that we all work a lot in our hospitals and we treat a lot of patients, but definitely there is not a person or there is not a support that would be at the like our side that would be guiding us how to get the confidence and the knowledge that would be helpful to crack the exams. We do not know most of the time what to read, and moreover I would say what not to read. Maybe we put our effort, our like time in the things that we actually don't uh, seek to know during our exam preparatory time. So less focus on academics, more we or the hospitals expect the trainees to focus on the clinical management of the patients. And now there is no more like anyone who would be guiding us during our MBBS or MD days. So we all have our like personal as well as family concerns. So definitely all these things make our life little bit difficult to prepare for any of the critical care exit exams. So now as a team, we are here to help you, and it's not only helping, rather advising, tips, support, assistance, and moreover, I would say guidance. Like I have told you, it's not about teaching, rather guiding you to cross this hurdle. So there are certain disclaimers. This is not an official presentation from ESICM. Whatever views we are putting here in our next 45 minutes to 1 hour of discussion, they are based on our experiences while preparing for the exams and teaching over years. The candidates, those who are preparing or those who will be appearing the exams, they are free to follow his or her own path, brain, and heart. This is something we always put in our disclaimer slides. And this is something that is being conducted or intended to offer you a better systematic way to clear both part 1 and part 2. As you have already cleared part 1, definitely it is now the last hurdle, that is part 2. So we all know what is an EDIC exam. I am not going into detail, but yes, the part 1, part 2 is our crux of our discussion today. That is the oral or clinical case exam. And I would say, and I will also accept that EDIC exams are meticulously developed and continuously updated. So you will not find the same questions, the same pattern which was being asked like 3 years back or 5 years back. So they continuously update their question banks, and that would be accurately reflecting what is their aim that they expect from the candidates. So they have certain clearly defined assessment goals. It would not be like haywire. From here they would be asking something, they from there they would be asking something, and something very non-specific in critical care they would be asking. So it would be very structured exam, and one of the very good, I would say, like the assessment way and the question pattern is very standardized. So for that, it is not so easy if you are not going through a proper channel or support system that would be developing or helping you to address the necessary skills, attitude, competencies, and knowledge that is required for the intensive care practice. EDIC acceptance, I would say now, most of the European countries, they accept it was one of their entry professional qualification in intensive care medicine as an attending. And in UK, we all know now it is one of the qualifying exam to get the license. And before it was only FRCA or MRCP, but now after the EDIC has been accepted, people find it very easy to enter into the UK working system. Now, how to start preparing for your EDIC exams? Not going into detail again, as you have all appeared and cleared your part 1. So you know the basic prerequisites that you have to visit the site, create your account, have one EDIC profile. Then you have to get the access to the S modules, and also there are certain like the links that you need to find out. Now, I'm not going into the nitty-gritties and the problems that you will be facing in your exam preparation, but I would say pull up your socks, because it is only 4 months time from now. So if you will be keeping it July, August, September, October. So in the November month, you are having your exam, and this is the exam date of the autumn session 2024, November 26, 27, 2024. So all in the 20s, 26, 27, 2024. Now, EDIC part 2, again, you all know, but there are like candidates who wish to know about the structure of the EDIC part 2. I would be saying that it is different from the part 1, as it is the oral and the clinical based exams, and this is following the model of an objective structured clinical examination, that is OSCE. And there is also the blueprint is derived from a structured competencies that is listed in the Cobertris syllabus by the ESICM education department. You may visit this link to know about the Covatrix system. I'm not going into detail related to the exam guidelines and regulation. If you open up the site for the ESICM, you will get everything related to EDIC. Now, candidates have to go through 3 to 4 clinical case scenarios, CCS, mostly 3 cases, and 3 computer-based stations, that is CBS, which includes biochemistry, image, curves, and graphs. And you have to compulsorily pass both CCS and CBS to clear the exam. So it cannot be that your total marks will be more than something, so you will pass. You have to pass the CCS as a whole and CBS as a whole. Maybe you like had the liberty to be failed in one of the stations, but as a whole, the CCS has to be more than their like set marks, and CBS have to be more than their set marks. Now, certain clues I want to share with you. This is something people find it very useful in the very beginning of their preparation when they have not decided how to start preparation. So the exam happens in the real case scenario environments, and the cases are the real cases managed in the European ICUs. So it is an European exam. So definitely the exam questions also come from the European ICUs. So in the online format of the exams, before CCS, you will be given a vignette or a case 5 to 10 minutes in advance. So this is the one clinical vignette only you will get 5 minutes before. Then you don't have the option to get the second, third 5 to 10 minutes before. It would be just as the examiner would be asking in the due course of the discussion. Then they will be showing you the second, the third, the fourth clinical vignette. And this normal, like the CCS one, if the first CCS, it would be lasting for almost 20 to 25 minutes. And they would be covering up almost 4 to 5 clinical vignettes. And each clinical vignette will have 4 to 5 questions after a short summary. So you have to answer the clinical vignettes question wise, and each question would be having the correct options or answers minimum 4 to 5, and each correct option or answer would be carrying 1 point each. So 4 to 5 clinical vignettes. In one clinical vignette, there would be 4 to 5 questions. In each questions, there would be 4 to 5 suggested answers that would be selected by or decided by the ESISM Education, EDIC Education Academy. Now, if you are right what they have actually suggested, so you will get full mark, 1 mark for each answer. So the more you answer, the more marks you get. So if you will be like out of 5 correct answers, if you will be only like be able to like answer 3 points, so it would be 3 by 5. So it will be calculated like that. Sometimes people answer 10 correct options or answers, but out of that only 3 are correct. So it would be wastage of your time. So for that reason also, we strongly suggest our course, the preparatory course, because as we will be discussing on in our the domains in week wise fashion, so it would be also more pointed, like you are to be very thorough how you are answering. It should not be the verbal diarrhea in front of the examiner. So it has to be very precise and to the point. So usually one of the CCS will be surgical, the other one is medical, and one from the subspecialty like neuro, cardiac, transplant, something related to that. Now, I would be only showing you some of the like the structure because we have the mock exam test questions by Dr. Manjunath. So I am not going into detail, but yes, the way how the CCS questions come in our like the last maybe 3 years of experience. So they would be starting with the question, summarize the case. If they have shown you a clinical vignette, the first one, then the preferable question number one would be summarize the case. And there are, like I have already told, 4 to 5 answers for each questions that are worth points. So the most likely they want to hear about are the organ dysfunctions and history, as we normally practice in our the national exit exams. So that is not very important in the European style of the exit exams. So they would be like expecting that you have to be very short, succinct in your answers. The next questions may be what is your differentials? What will be your immediate management? What further investigations would you want? And what can be the cause of some or other problems that would be mentioned in the clinical vignette, like fever, maybe some pain abdomen, hypotension, sudden deterioration in the GCS. So that would be the questions that would come up in the clinical vignettes. Now, maybe in the second or the third or the fourth, they would be like changing the track. So the first one, if it would be cardiology, the second clinical vignette, the third clinical vignette will not stick to the cardiology. So they would be like changing from the cardiology or cardiothoracic case to a neurosurgical case. Why? The patient is having bleeding due to like the heparin or like something related to warfarin, and whole scenario would be now changing to the neurocritical care. And then there would be supporting investigations that would be shown to you in the form of CT, X-rays to interpret. Now, there would be many questions related to the physiology also, maybe something related to evidence, something related to some standard trials, the practice guidelines that they would be expecting you to remember and answer, and also communication, counseling part. So that would be coming in the maybe the third or the fourth clinical vignette. And finally, as all we will be going through the typical our ICU case, end of life care, brain death determination, and organ donation would come up in the last few questions to know how complete you are an intensivist, to know about everything from the starting, the management part, the complication part, and the final, the conclusion part. Now, coming to the CBS. CBS are three stations. CBS 1 covers ECG, curves, and graphs. CBS 2 covers radiology. CBS 3 covers ABG and biochemistry, that is data interpretation. So these are the three broad headings in which CBS normally like happens. In the radiology, they would also put some of the echo, ultrasound, focus, all those videos or clips. Now, you have approximately 10 to 12 minutes for 8 to 12 cases. The questions would be in each of the CBS stations. And like as per the candidates' feedback and our own experience also, CBS is probably the most difficult ones because of the not the question standard, rather it is only related to the time constraint, because the question from the cardiology in the curve will change immediately to the ICP curve from the neurocritical care. So you have hardly your neurons any time to get adjusted that which system the question number 2, question number 3 from the individual CBS station comes. So it is tricky to prepare for them. So for that reason, your reflexes have to be really sharp in the CBS station. And they would be also coming up with a brief clinical information, which is very important. Many times, again, we normally advise in our preparatory courses that the clue is not in the big question set. Rather, there would be some or other image or like one liner that would be the clue to the answer. So maybe you don't need to read the whole, like, the vignette. Maybe you can read it, but you can pick up the correct answer just looking at that line or that word. Again, all the time is the main constraint in the CBS. Now, I am not going into detail. This would be all asked in the our different the domains in our preparatory courses. I would be just showing you if somebody wants to know that what are the curves and graphs normally asked. I'm not going into detail of these things, but yes, these are something right now. The last ones are coming up in our like last 2 3 years of exam preparatory courses. CRRT pressure trends, ECMO troubleshootings. So you need to know in detail about the curves and graphs. So do your Google, try to practice at work, and also discuss among your colleagues at the bedside. So that would be the clue that we want to like advise our trainees. Now coming to the radiology or images, we all know again a slide just for like just to scan through cities from the head to toe, X-rays, ultrasound, focus, echo. So it is something like I don't know that we will be going through in a very short time how to collect so much of information. But I would strongly suggest you should have your own question bank related to CT section, related to X-ray section, related to focus section. So that would be coming very handy just 10 days, 15 days before your real exam, because it is not possible, humanly possible, to go through all the like radiology, the curves and graphs in last 5 days, 10 days again from different sources. So we strongly suggest you should have it in your desktop, in your iPad, and start revising it at the last moment. Now, how to prepare? I know there are like, no, you all are like the very intelligent people, you know, you have already cracked edic part 1. So minimum 3 to 4 months are needed, and this is the, I would say, the best time. If you are delaying further, definitely you will be under stress, because you never know, your health is an issue, maybe you will be having your like, the official works, also hospital work, family concern. So you should keep a safe margin of at least 4 months time for this type of pricey exams, because it is not very like you would say very cheap exam, where like no, you are spending so much of money and also your time out of your busy schedule. So you should not take anything in light way. I am not going into again the way how you should be preparing, but I would say how you manage your patient at the bedside. That is the crux. Start with the sick patient, trolley it from the emergency to the ICU, how you start preparing the assessment for the ABC, then followed by the immediate investigation, in the delayed investigations, how to do the procedures at the right time, the medications you would prescribe. Then you have to also be attentive how you are stabilizing a sick patient, how you are discussing with your colleagues for the plan for the like the future like management. So all these things would come very handy if you are doing it regularly in your like ICUs at the bedside. And we strongly suggest at least for next 3 to 4 months before your exam, start making a protocol how like the sick patients are being managed in your ICU, because the same type of clinical scenarios would be asked in your exam. Like as Dr. Dhruv was telling, pancreatitis we discussed in our the gastroenterology domain, and that's the same type of case was asked in the real exam. So that is a cakewalk. So if you know what will be the questions and how you have to answer the complications, then the imaging, then the management, so it becomes very easy for you to connect the dots in the real exam. Now there are certain like other sources also, this like S modules or the packed educational academy, so that may be helpful as it is a European based exam. Now, I would be saying be updated with all the landmark trials, the recent publications, prepare notes, handwritten or your iPads or tabs or desktop. That would be helpful in your last minute preparations. There are certain like standard test books. I would not advise you to start reading from page number 1 now. It is too late, because 3 to 4 months is not possible to go through the Irwin Rippe or O's intensive care manual. But these are some of the standard reference books that you can keep when you are confused with some or other answers from your like preparatory courses. So there are certain internet resources that will be very useful. Everybody knows about that, but how you are using it wisely is the like essence. Life in the first lane, MCRIT, deranged physiology, up to date ICU one pager. So all these things are the invaluable critical care resources. There are certain examination way how you should answer, data interpretation, OSCE for intensive care medicine, ECG, then objective structured exam. This is the cases, and maybe I would like expect that all of you who are planning to appear your exam should your like keep your name from now only printed in this certificate. I would share with you all. Okay. and you will be having the real certificate where it would be 2015 would be replaced by 2024 November 26 and 27. So thank you, all of you. Good luck for your exam. And I know that you will be now stressed how to start preparing. Before I am handing over my discussion to Dr. Manjunath, so this is the plan which we are having, and this is something which we developed after so many discussions over like last 2.5 years, 3 years of our teaching. We start with the Module 1 study materials. The first one would be shared to all the registered candidates on 25th of June. Then there would be the examination on 1st of July. The examination link would be active for 4 days. We all know you are busy, so we cannot expect that you would be finishing the exam in 24 hours. So for that reason, this year we thought of allowing you or like offering 4 days time for the exam to be taken by all of you online only. And then on 5th, we are going live discussion of the exam mock test that we will be offering to you 4 days before. Along with, there would be certain things that we want to share with you related to that domain specific. Like if it is cardiology, so it would be something related to what are the expected questions apart from that mock test that we have the shared with you. So it would be followed by cardiothoracic surgery, neurology and neurosurgery. Then it would like follow whole like almost I would say 11 weeks. So 11 number module is there. So almost 3 months we will be discussing every week. And then there would be three mega mock tests, I would say, and that would be live one to one, just in the format for the EDIC Part 2 real exam. So we have devised this after so much of thorough discussion and also the experience that we had in our own preparation as well as in last couple of years. And this would be the team that would be helping you to like I would say cross this hurdle and don't lose this opportunity. I would be discussing you once Dr. Manjunath finishes the discussion on the CCS as well as CBS mock tests. Thank you everyone for your patient listening. Dr. Manjunath, you can share your screen.
I think you should exit.
I have
Not
exited.
you. Okay. No, I'm not. Yeah, one second. Yeah.
In the meantime, when Dr. Manjunath share the screen, any questions if you have, you can post in the chat box.
Hi, I'm Dr. Manjunath. So I work as a critical care consultant at Manipal Hospital in Whitefield. So as the tapas, I think, and he has already set the standards with all how to prepare for the exam. So when I think so when we gave the exam, like me and Jitendra gave the exams, I think and almost around 8 years back. So that time, so we did not have any orientation or towards this, especially for the part two. The part two is mainly it's not about you sitting and studying with like a under textbook. It's all about how you approach, how you make your and the strategy for the exam. That matters a lot. So as uh, I I put this slide in most of the exam going the topic and the related and the talks. So whatever we remember for the exam, it is the 10% of what we read and 30% of what we see and the 70% of what we say. And the most of the time, so if at all if you have heard something in that, the 20% will be what we have heard and the 50% of what we hear and see. Uh, and 90% comes what we say and do daily. So that matters a lot. So in the sense, here we are on the trying to tell you guys that whatever you do, the like a bedside, the same scenarios like will be asked in the exam. It is not under something cooked up. So these scenarios, they can take you anywhere. Okay. So as you all know, and you all will be working in the intensive care units, and you don't get a specifically respiratory case, the specifically cardiac case, the specifically neuro case. Okay, so they all will be intermingled with all the organs. It's like a vicious cycle. So the whatever we do daily in our rounds, in our practice, that matters a lot for the preparation. And I would not recommend anybody to sit and study for the exam for the next 3 4 months. No, it's not. It's not like that. I think just before the exam, I think around under 2 or 3 days, and if you have done any notes, and you can actually sit and do the revision of it. But the whatever you do from today onwards in your daily practice, uh, seeing at the ABGs, diagnosing the triple disorders in ABGs, uh, looking at the under CT scans and MRI. So what exactly to be told in the exam? That matters a lot. So if you see the CT scan, and if you can just tell the diagnosis, yeah, it does not actually matter. And you might have to tell the significant findings in those images. That matters a lot in the exam. Okay. So then comes, yeah, oh, sorry. Yeah, don't waste your time. As I've already told that sitting with the textbooks and the reading from like a page one, no. This exam, as you all know, and you have already under cleared the like part one. The part one is all about the theory to assess your knowledge. So now this exam is all about how safe are you as an intensivist? How is your approach for the intensive care unit, the patient? That matters a lot. So always you work on the approach and the treatment for all the case scenarios, and be always in the specific in your answers. And we don't encourage any and the stories about telling about the diagnosis. Once you see the scenario, and you should have a differential diagnosis. So your thought process should come in such a way that as soon as you see the scenario, and you should get the differential diagnosis. So we are here to help you out in the like a mock exam in all these modules to make you prepared for this exams, especially to have a thought process by seeing the scenarios. What exactly is the differential diagnosis? So then comes, so the CBS, the and Tapas has already told, these are the like, most important things where you guys actually do mistakes. So the CBS stations is hardly of under 10 to 12 minutes, and it is the most important and the difficult like part is and the time constraint. Don't waste your time if at all if it doesn't know some question. Please pass on the pass on to the next question, and you can actually come back and read that if at all if you still have time, and read questions carefully. Don't jump to the images and stick to the question, and always read the question in the question, and you will have at least around 10 to 20% of the clue will be seen in the question, and in the images or the videos, and you can see at least around 30 to 40% of the clue. So for this, the clue to get connected to your neurons and to your answer, and you need to do a lot of practice sessions. So look at the emissions. If you do practice sessions, the CBS will be cakewalk. So when I gave my exams, I think me and Jitendra had done a lot of practice. So the CBS was actually on the cakewalk, and for us, especially data interpretation. So next comes C, arterial blood gas analysis. Don't worry, I'm not going to read the whole slide here. I'm just put it here to make sure that, and you need to be aware of how do you approach an ABG. Okay, and then comes under something with the triple disorders. The triple disorders are something which actually, if at all, if you know to diagnose the triple disorders, you will get the diagnosis immediately. And these are the formulas. See, for you to memorize these formulas, it's very difficult. So what we recommend is start doing the calculating the compensation, the gap ratio, the gap calculation, and the correction in your daily in your daily ICU rounds. If you start doing it, these formulas will be in your fingertips. So for you, it will be actually helpful for the exam. So for the next 3 to 4 months, and you should be aware of all this and the formulas. The make sure in your daily note in the ICU, start writing about all this diagnosis with all ABGs. What exactly is happening with this patient? With the how much is a acidosis, the compensation, and alkalosis, and the gap to gap ratio, all that. So if at all if you start doing this daily in your practice, the your approach for the exam will be much better. So as we all know, as already told, that the calculations, if you start doing it in the last 1 or 2 weeks before the exam, it actually consumes time. So start doing practice and every day, and especially the formulas for compensation and osmolality, corrected calcium, and anion gap. Sometimes we know the formula, but when we implement it in the question, we might do some mistakes. So start doing practice again and again, which will make you perfect for the exam. So there are plenty of examples with these ABGs in Life in the Fast Lane, and there are a few other websites as well. But one, see, this exam needs lot of commitment, determination. So, and you need to sit and do these scenarios at least a week, at least around 2 to 3 hours. So if at all, if I show you this ABG now, diagnose the ABG and the causes of acidosis. So I'll tell you here, this is the CBS question. If at all, if you get in the data interpretation, so there is the something most important is the 40-year-old and alcoholic and absent direct light reflex. So this actually shows importance that he is intoxicated. And then comes and they given measured osmolality and the calculated osmolality. So this is to calculate for the osmolar gap. So with this, and they have given you already 60% of the clue in the exam. So as soon as you see this, and you should have a diagnosis that okay, it is alcohol intoxication with a severe metabolic acidosis. So if at all if you know these kind of MCQ in the sense for the scenarios, if you start doing it in practice and the daily in your like a mock exam in the modules, the whatever we provide. So with that and your approach, the exam will be perfect. So then comes for the data interpretation. See, there they won't ask you the scenarios what you come across on a daily. Sometimes these data interpretations are very tricky, and until and unless if you know about the topic very well, and it will be and easier for you to crack the answer. So these are the scenarios, so which, and usually they give the patients with the DK and HHS and the central what diabetes insipidus, the mixed edema coma, and HUS, the TTP and the DIC, and rhabdomyolysis and the tumor lysis syndrome, the refeeding and overfeeding syndrome. I feel it is their favorite, and the toxidromes. All these are the topics so which you need to give like most importance for the CBS stations. The images, see, whenever you do any approach for the exam, and you should have a systematic and way to answer, and your approach should be in such a way that as soon as you see the image, and you should go step by step. So here, always and read the scenario in the sense on the question and whatever they have given, and see for the abnormality or the treatment what they've asked for, and then comes the follow the basic rule with X-ray, the CT scan, or any ultrasound, the skin. First, see the skin, the soft tissue, the bone, and parenchyma. All these are the most important. Your approach should be in that way. And X-rays the most commonly, and they'll ask pneumothorax, Ogilvie syndrome, and some hardware devices, and many more. And the CT scan, the most of the time, so we'll just tell that okay, the patient has got an intraparenchymal bleed. So, but we'll not tell about the midline shift, location of the abnormality, and the features of the cerebral edema. So there is gyra and sulci effacement is seen. All this, though we can see that see all these findings in the CT image, we need to verbalize in the exam. Until and unless if you don't verbalize, and you will not get any marks. And the CT abdomen, yeah, the pancreatitis is like a most favorite, and they will ask you about CT severity index. So for you guys, uh, and if you get a patients with pancreatitis in your ICU, start looking at the CT images and start calculating the CT severity index, and see for any patients with Oglev syndrome, how do you treat it? Is it conservative or surgical? When do you do conservative? When exactly you do, and the surgical management. And pyelonephritis, patients with under long-standing diabetes, patient has come with some like shock and all that, so they'll give you some on the CT image with all the air pockets in the kidney. So it is emphysematous pyelonephritis. And ultrasound and echo videos. I think in my exam I had like a few of the echo videos. The patients with the severe AR and the patients with, I think, uh, a dilatation of aorta and all those the videos. It was there in my exam. So the short videos always correlate with the scenario. So and they must have given some and the history, like the patient had a chest pain and the following that echo was done. And all these echoes and videos start doing in your practice, and with that and you will become more perfect. And few of the videos what they can put across is the patient with pneumothorax, consolidation, and the stress cardiomyopathy, and the ventricular septal rupture. They'll give a history that the patient had an ACS, the following that he is in shock, awaiting for ECMO. So then it is ventricular septal rupture. He needs surgical correction, and the pericardial and the tamponade. Be aware of all the different signs. They would have put it across all the signs in the scenarios there. And the trauma patients, especially if they give some ultrasound scan videos, it will have the free fluid and the vascular injuries and the transcranial Doppler. So which is upcoming now. So and you might get a patient, the patient with the findings of the transcranial and the Doppler, and there is reversal of diastolic flow with brain death patients or SH patients where you can see vasospasm. So these, I think, all these are basics, and for you guys, if you are from the background of anesthesia, or if at all if you're from the medicine background or pulmonology background, yeah, you might have to work on this and understand the concept, how exactly overdapping happens, underdapping happens, which are the scenarios, how to manage it, and all that. So then comes ventilator graphics. So for this, and you should like start seeing in your ICU the ventilator and the screen, and start actually diagnosing it. If at all if the patient is actually uh, uh, has got a hypercarbia, in the sense patient with a COPD, patient who is in shock now. So and he might have actually developed an RTOP. The patients with severe VRDS and low compliance, and if there is any leak, how to troubleshoot it. The patients with bronchospasm, how exactly will be the under scalar and the loop. All these are, though you guys know, but you need to see that on the screen and answer it in the exam. I have seen many of my juniors, so though they are wonderful in their practice in ICU, but they don't verbalize in the exams, and they've lost marks and they have not cleared exams. So, but for this, I feel so when we were giving exams and we did not have any of these kind of courses. So, we used to do discussion on the bedside and then take it forward. So, but for you guys, so and you have an opportunity to have these modules, the debrief session, make utilize of it. And the second thing is be dedicated and committed. So the clinical case scenarios, I think when the Tapas has already told, I will not take much of this, and especially the patients with and the polytrauma. So the first thing is, and you will give an injection on the TT. Then comes the on the primary survey. Be aware of adjuncts of under primary survey as well. How do you do the resuscitation? And the patient, if it is in the shock, which grade of shock is it? The massive transfusion protocol, how to activate, and the tranexamic acid along with evidence, and whom all do you involve for polytrauma patient, and management of the uh, death triad of under trauma. How do you manage it? All these are important. Though we do all this in our practice, and you need to know how to answer this in the exam. So then comes a neuro. So it can be stroke or intracranial bleed or any GBS, meningitis, or anything. So always put up the answer as I'll involve a neurologist or neurosurgeon. Neuroprotective measures, my target are like so and so, and any changes in the, if at all, if you get a scenario and they have given that okay, the morning the GCS was like so and so, after 7 hours or after 15 hours the GCS is so, immediately your approach should be I will do a CT scan. So if at all, if you tell that, maybe in the next weeknet and you'll have a CT image of it, and any worsening of the general condition, and especially the patients with neuro issues, always think of complications of it. And if I tell you about meningitis, patient might be having any abscess or any other complications. And if at all, and if you take it as SCH patient with vasospasm or hyponatremia or SIADH or anything, and always for neuro cases or the patients with an ARDS, they'll go to the tracheostomy and be aware of evidence. And the most of the time, and if it is going for the long term care, they will go for all the hospital acquired infections, the VAP, CRBSI, the COTI, all that. And antibiotics, whenever you answer for any antibiotics for the secondary infections, the make sure I'll give I will start antibiotics as per the ICU nosocomial epidemiology. So this covers the most of the things in your answer. And so when they go for the long-term care, so then the scenario will changes to the critical illness, neuromyopathy, and then comes the rehab care, and they will ultimately end up in end of life care under situations. The GIT, yeah. So the most commonly it will be under GI bleed. I had a patient with under GI bleed in a click part two. So they had asked me about everything about the GI bleed. So whenever it becomes intractable GI bleed in the sense, and you have done all this on the terlipressin, endoscopy, antibiotics, all that is given, the still GI bleed is like a still going on. It means, and they're expecting you to answer on the sense taken tube or tips. And then comes how do you manage under coagulopathy? Will you give products for all the patients with coagulopathy or not? So the patients with liver failure does not require uh, the transfusion of products in all the cases. So after massive transfusion, if the patient lands up in hypoxia, always think that either it is in the fluid overload or it is in the trally, and look for the complications like SBP, HRS, and hepatic encephalopathy. So when you have a case scenario of a GIT, so what I used to do was, so when I gave my exams and they gave me the first vignette of all three cases, and they made us and sit in the room for half an hour. So what I had written was the my case was actually GIT, the second case was actually meningitis, and the third was I think under trauma. So I had written all the complications in the sheet, so that so whenever the I get the next vignette, my thought process should always be towards those complications. So you should be aware of, and every system and every diagnosis complications, how it will be. As an intensivist, we all here to anticipate the complications and manage it. And always the patients with acute liver failure, and we should know how to do the counseling for the liver transplantation. And other part is the pancreatitis. I think it is all the management part is like the most important. And if at all, if you go through the scenarios in our modules, I think the most of things are covered in that. And abdominal compartment syndrome, it is one of the complication of the pancreatitis, and you should know how do you like manage conservative and the surgically. Then comes cardiovascular. I think it's very vast, and Um, Coming to that, on the first, the cardiogenic shock, how do you manage it? And you should know about all the ACLS and the scenarios and defibrillation. And if at all, if there is a case scenario with out of hospital cardiac arrest, they might take you into brain dead under scenario or end of life care. And you should be aware of all these IABP and ECMO, the VV ECMO or the VA ECMO. How do you troubleshoot it? And when do you start antiplatelets in this patient and anticoagulation induced bleeding? How do you manage that? And also procedure related. If the patient is on ECMO or IABP and the limb ischemia, bleeding, how do you manage it? And the respiratory, this is a bread and butter of all of our intensive care exams, and you should know about the respiratory and each and everything. So, coming to the community acquired pneumonia and the scoring system, so they'll ask you to do the prognostication with the scoring system and the antibiotics and the rationale. Why do you start these antibiotics and ARDS definition? And you should be aware and the severity of ARDS. How do you approach for a patient with hypoxia, like mild ARDS, moderate and severe, and VAP, and the ventilator and the non-ventilator and the strategies? And you should be aware of each and everything, and with all the evidence as well, and the prone and physiology behind it, and also evidence and ECMO, preferably and VV ECMO for respiratory failure. So when this see when in your exam, if it goes for the ECMO or if it goes to the tracheostomy, the and your thought process should be ready for the next questions on the infections, hospital acquired infections, or critical illness, neuromyopathy. How do you manage these patients? How do you target protein intake, carbohydrate intake in these patients? Obstetrics, if you get a obstetrics, it is like best because there are only and a few case scenarios in that. So you should be aware of all the uh, pregnancy related physiological the changes, and how do you diagnose and the pre-eclampsia and eclampsia, the PPH. Whenever they take you to the scenario of massive bleeding, always remember involvement of interventional radiology for embolization, and always involve obstetrician and a massive transfusion protocol. How do you activate? And then comes the the ends scenario is, and you might have uh, taken the patient for LSCS, the post that the patient had a hypoxia and got intubated, the peripartum cardiomyopathy, and you should know the definition, the management. How do you manage diuresis and the rate control, and counseling the patient for the future pregnancies? I think 2 years back, one of my under junior had told, and he had a scenario where they had given the scenario that how do you counsel the patient with peripartum cardiomyopathy and to the husband for the successive um, pregnancies. So last comes end of life care. Always and speak with empathy and the compassion, and introduce and yourself, and ask about their understanding. How much is it? Uh, and the age and the background illness, give importance to it, and you make sure and you're under talking to the next of the kin, and tell about the prognosis of the disease and the benefits and the risk of the treatment is like most important. And also with the background illness, and you should know about a quality of life, dependency of daily living, and any see the most of the western population, they have a living will with them, so the make sure and you mention about that in the exam, and always be updated with European brain death guidelines and also end of life care guidelines. So these are the most important things I think, and what I've covered for almost all the systems and the most important. And next comes what we should do and what we should not do for this exam. The first is practice with a friend and your junior or your senior, uh, at least half an hour to 1 hour daily. So remember a 90% rule. So what I mentioned in the second slide, that whatever you say and whatever you remember, if at all if you do the discussion, and you will remember 90% of it. And always uh, develop good habits, in the sense, be dedicated, be under streamlined in your approach. And so we don't need hard work here, in the sense you sitting and understudying with all the on the textbook. So we need actually under smart work. So the create your own diagrams and the flow charts, the mind maps that turn the abstract and the theory into actions and the images, and start doing approach, how exactly you approach for the patient with hypoxia or pancreatitis, and start answering it yourself, and avoid cramming, in the sense, when sitting just before 1 week and before exam, reading up and everything. These are not the things to be followed for these kind of exams. It may be worked out for you in the past, but not for this click part 2 exam. And avoid multitasking and reading multiple things at a time, and eliminate this under student syndrome, because this exam will actually mainly test your the competency and the skills to be a safe intensivist. So always eliminate your the student syndrome, and start make sure that and you are fully dedicated at the work, and also for an exam.
Thank you, Dr. Manjunath. It was very lucid, as well as you have covered most of the things that the candidate should do. So, in the last page, Dr. Jitendra, anything you want to share before we will be requesting our successful candidates from the last session, Dr. Charabi and Dr. Dhruv, to talk about?
Nothing, sir. I think most of it, both of you have already covered it. So
Yeah.
again, a talk will be the repetition of the same.
Yes, yes,
We've
yes,
already covered
yes.
most of it.
Yeah, yeah. Thank you. Thank you, Dr. Jitendra. Now I request Dr. Dhruv. He is currently working in UK and he cleared the EDIC Part 2 exam in our last TRICS 2 course. So we thought of inviting him to talk about a few of his own experiences, tips and tricks, as well as his experience during our TRICS 2 course.
Thank you, Dr. Tapas and Dr. Manjuna, sir. And I really appreciate because the only dilemma during the preparation for this addict 2 was how to approach the patient that you already discussed in your slides. Uh, we already knew about all the things, but how to approach the patient in addict 2 OSCE exam is the main thing they want to ask from us. And as you said, if we can practice in our daily basis, that would be very much helpful for everyone. Even so, for my ECGs and ABG, I used to do daily 1 and 2 ECG. Even I used to study all this presentation which Dr. Tapas and Dr. Manjunath and even Dr. Sananta sir has said, and try to apply in my daily case scenario situation, like as you said, pancreatitis, and usually uh, uh, I used to do some flow chart things, so which include starting a case and including all the complication a patient could encounter in his progression and how to deal with it. So that makes you to anticipate the next question or anything which examiner can ask, and for which this tricks definitely helped me because I was lacking the approach for a patient. I knew about the stuff, but I didn't know how to express them toward the examiner. And with this all this system wise approach, it really helped. I even make the notes of each and every question, what's the principle of the concern, uh, as my esteemed teacher told me during their examination. And yes, I definitely will say that this tricks course involve a crux information which we need for to crack our exam, because there's a lot of curriculum we I mean one can study, but it going to be haphazard. So the tricks involve everything very precisely and makes life easy to prepare. Yeah.
Thank you, Dr.
Thank you.
Dhruv, for your the taking time out of your busy schedule from UK as well as appreciating our course. So
Yes.
now I would request Dr. Sharabi from Karnataka. So she cleared in her first attempt. She was like our student in the Tricks 2 course in the last session. Dr. Sharabi.
Yes, sir. So my journey with this entire EDIC exam was not that smooth. I started preparation in January, but it had a lot of ups and downs. Like you said, preparing for the next 4 months, it is not easy to go every day consistently. But one thing that I stuck to was I stuck to the plan that you guys made for us. So every week, whatever the subject that we were supposed to study, I would just sit and solve that exam, and then read about the topics that I was lacking and that I was not aware of or I was weak at. And then further, when the videos were released, I would just go back and then again make my notes and do all those things. So this, like Dr. Dhruv said, the structured approach was what we were needing. Because I think to appear EDIC exam, one is you have to have enough experience in ICU. Without that, I don't think you can just mug up and go and give this exam, because you have to be practicing all this prior to giving this exam. Otherwise, it becomes very made up and you will fumble during the exam. So you have to be practicing whatever you're preaching. So if you have seen a variety of patients, including cardiothoracic, neurology, neurosurgery, septic patients, surgical patients, onco, then I think it is of a great help, because you would have come across all sorts of applications already, and you would remember, okay, they had done this, we had done that. But then if you have to produce it in front of the examiner, then you need a structured approach, and that is what I think we learned during TRICS classes. It's not like the class will teach all the theory and stuff, but it is the best way to guide us as to what path to take. So that, I think, for us, that is the most important thing, because theoretical things we can go back and read, but to how to go about it and how to approach it, like both of you mentioned, I think that is more important, because theoretically anybody, we can just go back and read about it, but how to approach and how to be confident on the day of the exam, that I think the classes help. And also the mock tests, because once you have given 2 3 mock tests, by the time the exam comes, you will be confident enough to face the exam very easily. So I think the mock tests also helped a lot. So yeah, that's my opinion.
Thank you, Dr. Sarabi, for your the ideas. So the structured approach. That's why we named our course as also tricks. So it is not review, rather it is targeted review in
Yes, sir.
intensive care trick.
Yes,
So two
sir.
things I want to share in continuation with Dr. What like she told. It is better to sweat in peace than bleed in war. So I always post this in last like a couple of years in our different groups for the candidates to wake up. So it is not very easy. So stick to the timetable, stick to the domain that we are discussing, and also try to join the live debriefs if it is happening. Because people normally think that I will go through the recorded version, but this is our practical experience. You keep it in your folders. You don't try to finish it in one go. Rather, you take it like no 5 minutes of one question, then stop, then do your like no the other work, then again like think of doing it in the next day. It never happens. So yes, it is a standby thing. If you have some emergency, if you have some hospital work, so it would be there for your like no revision part. But always, as we are planning this time to restart the live debrief. So if somebody is joining, so this is my sincere request to join live debrief. You have to pay something to get something. So that's the thing that we expect. Don't be like taking the things so lightly. Rather spend of your like 2 hours in the live debrief, and you will feel the confidence after attending that live debrief. So I think most of the things have been discussed. So I request if any of the attendees, if they want to like ask any query in the chat box, or like no they want to share anything from their own expectations, so they can post in the chat box, and also they are free to share it in our WhatsApp group, the dedicated WhatsApp group that we have created for the free webinar. So, and the agenda and the registration details would be shared with you in the WhatsApp group by my team. And we wish you all the best. We wish that all of you should be having the edictus, the clear certificate with you all at the end of your hard work in the next 4 months. And believe me, we have almost right now helped more than 500 candidates to clear in the last 6 sessions. So that is something which we take pride, and this is our the whole idea of starting this preparatory course. So anything from the faculties, or else we can close.
Suppose
Yeah, I
Sanant
think.
here.
Oh, hi,
Um,
Sanant.
Yeah,
Hi,
Sanant.
Manjunath, and sorry, I'm a little bit out of the plane actually. I'm in Japan now, and um, but still I try to connect while in my way somewhere.
The
Um,
Japanese takoyaki, what is that dish? Popular dish? Teriyaki,
no
teriyaki.
idea.
Mhm.
Yeah. All right,
Yeah.
I mean, just I wanted to highlight 2 points very quickly. As Chavi and Dr. Dhruv has said, this is not a course that we can teach people. We just give them the approach, how to approach this exam. And 3.5 months or 4 months is not a period that you will learn intensive care. You will polish your intensive care. That's the main aim of this. And how you approach a alien examiner, that's the way. That's the thing we focus on, and we try to teach you so that you connect your knowledge, what you have, and your experience to your success. It's basically a real game, this exam. Even if people know a lot, they fail. And people who can talk well, who can present well, they pass. So that's the main aim of this course is make you acquainted what is required, how do you present, how do you hold yourself on the day of the exam. Um, as Tapas was saying, the live debrief are very, very, very important. Yes, people can have some issues in terms of not getting time, but it should not be a repetitive thing. We encourage everyone to attend a live debrief because that's the crux of the whole course. You can see the recording, but it doesn't give that feel. There is an interactive debrief always. More than 10 debriefs will happen. So that is the most important thing that people who are going to enroll into the course should look forward to join. Yeah, that's it. My input from the whole experience that I had for last 5 or 6 sessions that we're conducting. Thanks, Tapas.
Yeah. Thank you, Dr. Sanant. So there are certain questions in the group. What is the pass mark by Dr. Muhammad Salahuddin? I would say more than 65 to 70% is a safe zone. So if you click 7 questions right out of 10 correct answers that they expect, so you are into the safe zone. And then what is the total duration of exam? Dr. Said, it would be you are preparing for 4 months and the exam would be finished in less than, I would say, total, if you will calculate the time, less than 2 hours. So it is normally for 2 days. So they put CCS on the first day or CBS on the first day, and the next day it would be the other one. So totally, if you will see, it is 1.5 hours. And so I think the Dr. Dhruv and Dr. Chabi should be the persons who would be answering this question. What is the total duration?
Uh, CBS was finished within an hour. And
Yeah. So you
when
just
it
enter and
started
you
and
start.
finished, yeah, it
Yes.
was like whoosh
Time
when it
will not
started and yeah.
matter, sir, because once you enter, you just
Yeah,
don't know when it went.
Yeah, you go with the flow. You go with the flow.
Yeah,
yeah.
Yes, yes, yes,
yeah.
yes. And
Uh,
Dr. Prasant has asked a question that in CBS, can we go backward to answer if any question is left? Dr. Dhruv and Dr.
yeah,
Shabi?
Dr. Chavi, if you want to ask.
No, no,
Yes,
both
sir,
of you.
I did the
No,
same thing. Like I was very quick in answering whatever I knew, and whatever I didn't know, I went back to them and I answered because that gave me enough time to think about it in detail. If I,
So,
at first sight itself, I knew that no, I don't know this question, then I just skipped right ahead. So I think
Yes.
so
that helps.
when the time is left after answering all the question, you can go back whichever question you want to or review.
So don't like no, just wait, and the
No.
examiner would be also fed up that
Yes.
what you are trying to do. So if you don't know, just skip to the next question and answer that question. It will give you
And
confidence, and also that will save your time so that you can return back to
and
the question that you have not answered.
and
Yeah.
believe in your answer. Don't believe in their poker face. So
Yeah,
keep on
true,
answering.
very true, very true.
Yes.
They'll not have any expressions like the Indian
Yeah,
examiners.
yes,
Yes.
sir.
Yes. Yes.
So just answer and
So.
go
uh,
forward.
So you will be disguised. Sometimes, like no, people feel that my examiner was smiling little bit, but you don't
Yeah.
know that smile is actually no something in the opposite direction. So he was smiling by your foolishness of your answers. Yes. So don't go with all these things. So these are something which we do in our national exit exams, but the European exams, they are very professional and they are to the point. They will not be like expecting you to like no portray with a poetry or like no something like very dramatize the situation, something like that. It would be to the point and save your time. That is the most essence part. Yeah. So any more questions, friends? So any doubts, please post in the WhatsApp group. We will be continuing with that group for disseminating the information. And we wish you all the best. And we are just on the like 1 hour time. We started at 7:10. So best wishes, and definitely we will be there to help you all. Thank you all. Thank you all the faculties for your time,
And
and see
Thank
you
you, sir.
soon. Thank you.
Thank you.
thank you, Tricks,
Thank you,
for
sir.
Super.
Thank
for
you.
all the helpful
Thank
given.
you, and all the
Thanks a
best
lot.
for all the candidates.